joint.
Okay.
And so this is his tuber sacrale right here, and this would be his SI joint region.
Okay.
We're looking for kind of areas of uptake here, all looks normal. The reason that his tuber sacrale here are hot is because, or high uptake, is just because they're really close to the camera, because they're the bits of bone that stick up, so the camera's like that far away from them.
Right, okay.
And then this hot spot right here is his bladder. The isotope is excreted through the urine,
Right.
so the bladder always is
Okay.
a hot spot. And then, so moving on to where we
So in general, his back and sacrum is good.
his caudal back,
Right,
his
right.
hind back, yeah.
Right, that's
so
what I
then we move
meant,
on
yeah.
to where we found the most significant
This
findings on
getting
his
to the
bone
neck
scan.
and-
Yeah, it was.
okay.
So you can see so this is his ribs and sort of thoracic spine at the top here.
Okay.
And then this is a sort of high on view of his thoracic spine. All looks pretty normal. This is his jaw. You can see his teeth. Yeah. And so this is his high neck here. This is his mandible, his jaw
Okay.
right here, and his neck's coming down here. So the rest of also be here. And this is
Okay.
on the other side. And as we come down, this is the images that started to show us a little something here. These spots right here. So this is his shoulder right here.
Okay.
His head would be up here.
Okay.
So this is his lower cervical spine, we call it.
So this is just like right above his withers?
This
Or
would-
just,
his withers would kind of be up here.
right, okay.
So this is his neck.
Right,
This
yeah.
is his neck bones.
Right, yeah, the neck, yeah.
So this is, if you can you see that his jaw is here?
Yes.
And this is his high neck. This
Yes.
is kind of following down from here.
Okay,
So
alright.
this area here and just basically between these are the joints between the cervical facet bones or
Mhm.
the cervical vertebrae, and they're a little hot. I think the
Okay.
radiologist thought that this was the most significant finding
Okay.
on the bone scan. So that gave us definitely something to look at there. And so when the next thing we did was, we obviously did the lameness exam as well, and saw that he was kind of ataxic, but also, he was showing a predominant left hind lameness as well.
Mhm.
So with all of that, we went to ultrasound. Let me show you this is his left hind suspensory ligament. So this is right, so you can imagine his hop is like this.
Right,
And his suspensory ligament inserts right here.
okay.
And then comes down and comes around the ankle, inserts in the front of the plastum.
Okay.
So the suspensory ligament is in this area here. And where we're scanning right here, so I'm taking a cross section through his hock about here. And so I put all of his tendons out the back here. His deep flexors like this, which is this big circle here.
Okay,
And this is his suspensory ligament. And it's because it's difficult to see a great image of it because it's so far in, and especially on a
Right.
big horse.
right.
So the sound's got to penetrate all of that. We were just taking measurements here. You can see we've got a measurement of about 1.5 centimeters, which is, almost within the normal range, but just the size of this tendon, you can see
Mhm.
between the two X's,
Mhm.
in comparison to the size of the deep flexor, it's much bigger.
Okay.
And so that's a little abnormal, a little
And
large.
that would be caused from an injury, like swelling, or?
So that would be caused by what we call suspensory desmitis, which is
Right.
inflammation within the tendon.
Okay,
Now,
yeah.
suspensory tendon is kind of different from other tendons in that it has a fibrous capsule around it. And at the top it actually opens up, but right throughout the whole of the rest of the tendon it's kind of encapsulated by this thick fascia.
Right.
So if it gets inflamed from an injury, like
Mhm.
a small tears or just overuse,
Mhm.
or poor foot conformation, or he just happens to have a little tear in it, it kind of swells, but it can't swell because of the big capsule.
Okay,
Yeah, so it kind of creates this cycle of swelling, and then it can't swell, so there's pain, and then it goes down, and it gets even worse. And it's kind of like a cyclic thing.
okay,
And it's all caused, a lot of it's caused by the capsule.
okay.
Because it's just like a compartment syndrome,
It can't expand.
So we continue to just scan down his leg, and this is kind of from a longitudinal section, like the other direction. So this is his cannon bone, the top of his cannon bone. This is this slope right here.
Okay.
Right here. So this is where it's inserting. I'm getting an image of this is the tendon inserting on the cannon bone. This should be this is his right hind.
Should
this
be
is his
smooth.
left hind. And it should be a nice smooth bright white line through here. And it should be a nice fiber pattern. It should look like we were looking at a packet of spaghetti from the side. You see this is his superficial tendon right here. His deep tendon, you can see the spaghetti fibers.
Right.
Really nice white bright lines. The collagen fibers are all lined up. Here should look like that, and it doesn't look ideal. I mean, it's difficult to image this area, so it's not that sensitive a modality, but
Right.
at the same time, we should be seeing a better fiber pattern through here. So we weren't too happy with the fiber pattern.
And it's worse on the left.
We think worse on the left than on the right, yeah. So again, this is just comparison left and right, and the tendon looks a little bigger on the left. A few areas of like echiness of sort of high reflective sound pattern through here. So, and again, this is the deep flexor, and it looks a lot bigger. And this is just further down that same longitudinal section. We're taking measurements, and these are actually close to within normal limits. So I don't think it's too bad, but it's definitely something that's bothering him. That's there. The fiber pattern's just not as ideal. You can compare it to this tendon up here.
Oh yeah, definitely.
So we just went down the leg, and this is at the branches where the suspensory tendon, when it's just above the fetlock, it splits into two
Okay.
and goes down around the ankle, around the
Okay.
sesamoids and around the ankle. So this is just where it splits, and I think we're looking pretty normal down through here.
It doesn't look as bad down there.
Yeah. And then we assess the branches. These are his suspensory branches coming around the ankle on the left and right, and they look pretty normal, I think. Until we got to the attachment of the sesamoid. Now this is on the right lateral, so this is his right outside leg
Okay.
onto the right outside sesamoid.
Right.
And he has this again should be, this is where the suspensory attaches to the sesamoid bone,
Okay.
distal in the leg. And again, he's got this little thing here, this little avulsion off the sesamoid. So this should be a nice straight line through there.
That's
It
the
should
leg
look like
hung
this.
up.
Yeah, this is what it should look like. This
Okay.
is his left
Left.
lateral,
Yeah.
and this is his right lateral. You can see he's got this. So this is just a little bit of remodeling, because he may have, that tendon is really tight there, and it may have pulled off a little bit of
Right.
the surface bone. So I think this is abnormal and can definitely be a factor for him. Then we look at the medial, and on the left medial, he has a similar thing. So the right medial looks normal. This is the right inside of the leg, looks normal. So the right outside is abnormal, the right inside is normal. And the same on the left.
That's so
So
weird.
another little one on the left, yeah. So just something to be aware of as well.
I mean, that's so.
I'm sorry.
No, it's fine.
Hello? Okay, we should be okay for, I'm just going through the images for the minute. So we'll just probably be 5-10 more minutes. Okay, thanks Rachel. Bye. So again, like just some little findings that we found that, I think could warrant further investigation down the line, but we've got more major problems to deal with at the moment.
Yeah.
So then we come to his neck, and we just took some, like this is when he was still sedated for his limb ultrasound.
Right.
So we just popped the probe quickly onto his leg, onto his neck, because we had seen the hot spots.
Right.
And this is his C6, C7 cervical facet on the left-hand side.
Okay.
So do the left first or the right? I think this is the left. So this little
Was it the right?
gap
That's his
here-
right there.
Oh, sorry, right. This is the right was worse on the bone scan.
Okay.
So I just had the probe on the right here, and this is supposed to be his joint. This tiny little line right here.
Uh-huh.
It should look like a nice smooth line, a little divot, and then another smooth line as we go to the caudal facet, the
Okay.
cranial facet. And this white line over the top here that forms this kind of triangle,
Uh-huh.
this is the joint capsule, that
Okay.
joint. Okay, so this looks a little uneven with the joint as well, looking a little bit small. We just got a few images. This is the joint right here, and this is his 5-6. So this is a little cleaner, but still a little abnormal.
Okay.
And then I wanted to show you the neck X-rays that we had. So this is up at the top. This is obviously his head, and this is C1, C2 right here. He has 7 cervical vertebrae. This is the one that kind of forms those like bits that you can feel inside of his neck. We come down to this lower cervical spine, still this kind of the mid-cervical spine, still looking normal within joint spaces. But then on this one, so this is again difficult to image because Saint's a big horse, and all horses are difficult to image in this place. But we just increase the brightness a little bit. This is number 6, his 6th cervical vertebrae. So this would be C6 and C7. So this is the joint we're talking about here.
Okay.
And he's just got this little bone remodeling over the top here. This shouldn't be here. You see these little wispy lines? This
Okay.
shouldn't be there. And the joint space looks small and kind of uneven through here. So I think he has a little bit of arthritic change through there. The radiologists were pointing that out as well, I agree. And so, you know, along with from the bone scan and the neuro exam and the x-rays now with, you know, and the ultrasound of his neck, I think we were pretty confident that there's definitely some change, some arthritic change in his neck.
Right.
Could definitely be responsible for some of his neurologic signs by just compressing the spinal cord at that level. And so what we've gone and done now is injected those joints with a steroid. Almost
the C6,
like
C7?
And C5, C6.
And C5, C6.
So we put a needle in, down, ultrasound guided needle, both sides, down into the joints, and injected them with steroid that's going to be pretty potent anti-inflammatory.
Okay.
Kind of like a Hock injection.
Right.
But for his neck.
And then, so then we give it like, Dr. Hummel said, 3 to 4 weeks, and then bring him back and check him again and see if he still has the neuro symptoms.
Yeah.
And then if it doesn't resolve from that, it's a pretty good sign that we're heading more towards a potential wobblers kind of situation at this point.
I think at that point, you know, we might want to repeat the cervical films or get a closer look, you know, get someone to put in the measurements to really assess whether he is. The other thing we can do is a myelogram.
Yeah, that's what Dr. Caldwell mentioned.
To assess, because we can see the spinal canal, it's here.
Right.
But that's just the bone.
Right.
So we can't see any, it's difficult to see any narrowing just on x-rays alone. We'd have to do what we call a contrast study, which is the myelogram. And that's when we inject a contrast material into the spinal canal. And when we repeat these films, we can see how much space the spinal cord then has.
Okay.
Yeah, that's the best. We usually lay them down under anesthesia for
and
it.
that's what Dr. Caldwell said, and he said it's an issue with him potentially getting back up if they're neurological.
Yeah, so it's always a concern.
And if it is that, then there's not a lot that can be done. So there's surgery, but it's relatively major and
it's very major.
Yeah.
So
Yeah.
the surgery,
That's what he said, isn't that? Like he said, you guys couldn't even do it here. We'd have to. Yeah.
Yeah, there's only a few people in the country that are doing it.
Yeah.
And they do it a good job, you know, but you know, it is a very major procedure.
Well, so talk to me about the suspensory because.
Right. So I think let's just hold our horses on getting into
Yeah.
to have his neck fused.
Yeah.
I think let's see how the neck injections go. We think that he has a bilateral suspensory desmitis as well. It's a concurrent injury.
Right.
And so for that, the initial treatment, usually we try and do some conservative therapy first, so some rehabbing of that tendon and see if he's responding to that. If he doesn't respond to that, there is a surgery that we can do, which involves cutting that fascia I was talking about. So that compartment, that's fascia that's holding that suspensory tight and not letting it expand.
Right. We
can go and cut that, and cut the nerve that supplies that tendon.
So that's like nerving if you have a horse that has navicular? Is it the same sort of thing?
Similar.
Right?
Similar. Now, nerving for a navicular thing, we consider that a salvage procedure.
Right.
Because the horse is not going to be athletic after
Okay.
that. Because you don't know how much damage the navicular bone's done to the tendons down there. And usually I would personally want that horse to have an MRI to make sure those tendons are okay before I go ahead and cut the nerves. I think Dr. Caldwell would probably agree with that. The suspensory is a bit different because that nerve, we cut just a single nerve that supplies that particular tendon, and it doesn't affect any of their peripheral sensation.
Right.
So he would still be able to feel his feet, feel the back of his leg, feel if he cut himself,
right.
Feel all of that kind of stuff, and the nerve regrows. It's just a matter of time.
So he could still potentially be athletic.
Yeah,
with
a lot of horses are athletic with this surgery. Yeah, it actually has a very good success rate.
Like athletic what, tricanter, or like athletic
like
jumping
athletic high level
and
competing horses.
Okay.
Yeah.
But so
the
what's the therapy for now? Do we start with just rest him, right? You said.
So right now our plan is, you know, we keep that in the back of our mind and let's make sure that we can treat the ataxia. There's no point in laying him down and doing these surgeries if he's going to continue to be ataxic afterwards, because it's a complete waste of your money.
Right.
What we do now is we've injected the neck, try and get the inflammation in those joints down, see if that improves him. So we're going to send you home with some instructions to rehab him for a suspensory desmitis, with some stool rest and some hand walking.
Okay.
So I'd start off with 10 minutes twice a day, or if you can do just once a day, that's fine.
Okay, so he needs to be on actual stall rest?
Yes.
Not out?
No.
Okay, alright. Cause when I talked to Dr. Caldwell, he mentioned he could be out if he wasn't moving a lot, but
Yeah.
but we're going back to, so now we're.
No,
stall.
I'm happy with that. If he
Okay.
can be out and not move, you have a small paddock.
Like in a round pen kind of thing,
Yeah,
or
you
a
can do
small
that.
paddock where
Yeah.
you can't, okay.
Yeah. So I just said stall, but anything similar.
Okay.
If it's easier for him to be in a round pen or in a small paddock if he's not running around,
Okay,
that would be okay as well.
okay,
But what I've, so just take what I've written in the discharge where I say stall and just change that for round pen, whatever,
Okay.
it depends what everybody's situation is different.
yeah,
what they have
no, we'll just
at
have to
home.
figure it out.
But mainly we wanna
The
rest him a
blind
little
horse
bit.
that takes up the round pen.
Mainly we wanna rest him a little bit because he is ataxic,
Okay,
so I
right.
don't want him charging around the pasture.
Yes,
And
no, and
then-
he will charge.
For the suspensories, it's
So do we
very-
think the suspensory potentially was caused from the issues with the neuro? He couldn't,
No, I don't think they're related like that. A lot of sport horses have suspensories.
Okay.
He also has what looks like a little bit of a palmar angle on his hind feet, which is probably putting a little bit of tension on the suspensories. Plus a lot of horses.
what do you mean by that palmar angle?
So
That,
his,
like
his
heels
instead of
are-
his foot being, the sole of his foot, the bone of his foot, sorry, being like this, it's
Uh-huh.
kind of a little bit like this.
So then
To do that, we would shorten the toe a little bit
Uh-huh.
and just let his heel grow a little
let
bit.
his heel grow out a little bit more? Okay. So,
Try and bring the shoe back using his break over. I've put all of that in the discharge.
okay, I'll give that information to my farrier. Would we be thinking like a corrective shoe?
No, I don't think he needs a special shoe.
Okay.
In fact, I wouldn't put him in a wedge.
Okay,
That's generally a route to just it always needing to be in a wedge, always having to
Right.
increase a wedge.
right. We've got him his front, he's got quite low heels in front, so that's why we've got him in the hard bars in the front.
Yeah.
But the back, we'd only just put him in shoes about a few months ago,
Yeah.
maybe 6
Um,
months ago.
I would just continue to get him trimmed. Just mention this to your farrier. And we haven't got foot x-rays off him, so it's difficult. It might be something to recommend later down the line once
Okay.
if he starts getting back to being more athletic.
Okay,
So we're gonna start off with some stall or round pen rest with some
Okay.
hand walking, so forced walking
Okay.
at a good pace if you can.
Okay.
Like 10 minutes twice a day
okay,
for first week, and then in week 2, so you're gonna bring him back in about 4 weeks, right?
Right.
So we split it into week 1, week 2, week 3, week 4.
okay,
So week 1, about 10 minutes twice a day, or if you're gonna do once a day, that's fine.
Right.
Written twice a day though.
okay,
And then week 2 would be 15 minutes,
okay,
and week 3 would be 20 minutes,
okay,
and week 4 would be 25 minutes.
okay,
Okay.
hand walking.
Hand walking. Well, if you want to put a saddle on him and walk him under saddle, that's fine.
That would be okay with the neck injections and stuff?
So for the neck injections, we're just going to give him some rest for 3 days.
Right, okay.
So no forced exercise for the
Right,
first 3 days.
okay, okay,
And I would start off with maybe in week 1, just hand walking, and then maybe when you get to the 25 minutes, maybe you could do 5 minutes of hand walking, and then the rest on the saddle, just to
Okay.
warm them up a bit.
just to give him a little bit.
I would try and do it on a fairly firm surface. If you have an arena or something with really deep bedding, that's probably going to stress his tendons.
We're
more.
mostly grass.
That's perfect.
Okay,
Yeah, grass would be perfect.
okay,
And butte for 3 days, and then once that's kind of stopped, then start him with the walking.
okay, alright,
Okay, I have a CD of all of these images that I've
Okay.
put with your stuff, and
Alright.
you should be able to put that in a computer,
okay,
and it comes with a program so that you can view the images.
perfect. And the discharge, you said you have all the discharge stuff written down?
Yeah, I think Stephen may have given it to you, but if he hasn't, I'll make sure that he's
Yeah, I'll double
he's
check
printed
and
it out.
make sure it's
I'll go
in there.
through it with you.
Cause I think when he printed everything out, he said you were still finishing the discharge, so
Okay.
he may not have given me the actual written
Okay,
instructions.
I'll get that written. I'll get that
Okay.
printed out for you.
And then for the adequan, I do that like in his neck?
Yeah, in his
Okay.
neck's fine.
Okay.
Yeah, just muscle in the neck. So get the syringe and the needle,
Mhm.
draw up the stuff with
Okay.
the needle, and then have someone hold the horse for you.
Right.
And just inject into his neck. So I put the needle into the neck, into the muscle. He's fine
Right.
about it. He shouldn't
Right.
be too bothered. Just pull back on the syringe, make sure there's no blood coming.
Okay.
If there's no blood coming, just inject it.
Okay,
Okay.
alright. Okay,
If you-
so it seems like if the suspensory can heal and the neck is actually from this arthritis, he's potentially could be athletic again and used again?
Yeah, I mean, if the problems can be resolved from what we've done, then I think that there's every chance he can be athletic again. Yeah,
Okay.
sure. But we've got to get the next. We've got to get the ataxia.
Right, you gotta get obviously,
So if
you
he-
can't have a horse running and jumping who can't feel his feet.
I mean, he can feel. He's not completely aware of where they are at all times.
Right. Okay,
And I think he's definitely got some suspensory issues as well.
okay,
Which are kind of making it even harder for him and behind. Because when we were lunging him, he was bunny hopping behind,
Yeah.
and then he would cross canter. He'd be on like the left lead and behind, and the right lead at the front, and then he would realize and switch back, and then it would hurt, so he'd bunny hop again.
yeah.
So,
No, I mean, that's the kind of stuff that we were seeing that we were like, okay, we need to get this checked. So,
and then when
because his canter, a year ago, his canter was much better,
Right.
so, yeah.
so hopefully, he doesn't have wobblers or anything like that, and this can help him out. But we're really gonna know in about a month.
And so with these like arthritic changes, is it something that, so if the joint injections work, then it would just be a matter of maintenancing and getting joint injections as needed,
Yeah.
and then,
Maintaining him on kind of joint supplements like Adequan and
Adequan.
Legend.
okay,
I know Legend's very pricey right now. I'm not really sure how your budget works out, but there are other more generic forms of Adequan as well. They're a little bit cheaper, but
Right.
not quite as effective, but still are a little effective.
but in general, injection type, the kind, like this is an injection as opposed to like a supplement.
I mean, there's absolutely no harm in giving him oral supplements,
Right.
joint supplements, but I think that that's not going to be able to maintain.
It's not gonna be what it needs. And so, with these changes, do we think it's just because he's big, or do we think it's from like an injury that caused him, or?
Could be from a traumatic etiology like that, as you mentioned. It could be just him. It could be that he's hurt his neck at some point, and this is just the remnants.
The remnants of it.
And I think he's going to have some arthritic issues in his neck for the rest of his life.
Okay.
And that we are going to be managing it. It's kind of going to be like managing a horse with hock arthritis. I'm sure
Okay.
you have come across plenty of horses that have their hocks injected.
Yeah, no,
So,
absolutely.
similar kind of thing,
Okay.
except it's just a little bit more complex to perform those injections.
It's just frustrating because he's so young.
Right.
And we brought him along so slowly because he's so big, and we tried to do everything right. And I'm
Yeah.
like, what did we do that we?
You had a good horse.
Yeah.
Bad thing to always happen to good horses, and I don't know why. It's really frustrating. I'm really sorry.
Yeah.
But hopefully, in a month's time, these do reduce some inflammation, and he becomes more comfortable behind, and then we're going to be able to rehab the suspensories,
Right.
and hopefully get into a stage where you have a competition horse.
Well, it would be great because I'm worried because he's so big and his movement is so big.
Yeah.
He's not going to be the kind of horse someone wants for walk, trot, canter. He's not I'm going to go out and be like a chill, like trail horse. He's happy enough to go on a trail, but he might go in the other direction unexpectedly.
But he's also
So-
still a baby, so he'll
Yeah.
mature as well.
Yeah. Okay. Well, I mean, this sounds like a slightly better prognosis than I originally thought.
Well,
but
I mean,
it's
I
still,
don't wanna,
it's
like-
not, no, it's not positive, but it's not
I think we've got some answers.
there's possibilities, more possibilities than I thought there were.
I think there are some possibilities. I think right now what we know is we have some answers, we have some problems to be working on.
Right.
We have a plan in place to hopefully, be more precise about what's going on. If he
Right.
responds to this, I think we have more of an answer.
Okay,
And we've ruled out a lot of bad stuff.
okay.
So that's really important as well.
And so with the back, I don't need to be wrapping or anything.
No, you don't need to be wrapping, right? He doesn't need any wraps on him. I mean, unless he's used to having stable wraps. he
No,
gets
he's
stuffy or
not. I
something.
don't normally wrap him. I mean, we're wrapping for the trail
Trail
ride
ride.
because it's so long and he's a little stuffed up if I brought him up here.
Yeah. So yeah,
Yeah.
I mean, and then, bring him back in 30 days. We'll reevaluate his neurologic state and his lameness state. Hopefully, he should be starting to respond in the tendons as well from your rehab program.
Okay.
I will say that like the rehab program for a hind limb suspensory usually is effective about 30% of the time.
Okay.
The surgery has an 88% success rate.
Okay.
And like a lot of people have done studies on these surgeries because it's a lot of small horses have suspensory issues, and so it's a major deal. You know, people want to fix it. We do the surgery here. We've had a good success with it, and so it's definitely something that we could maybe address if his neck's better.
Okay.
So.
All right. Okay. Well, then we see what happens with the neck.
And you're probably gonna have a bunch of questions you forgot right now.
Yeah,
it's my phone numbers on the. Our phone number is on the discharge.
On the papers.
And I have my phone number 24/7.
Perfect.
To answer any
Excellent.
questions, so just ask me or Dr. Caldwell.